Good evening, a very nice evening to all of us, and I believe we are okay. Once again, my name is Dr. Power Paul. I have my team here from the Paramedics Hospitals Africa, and remember, we are bringing to you this training in collaboration with Covenant University. So their representative is here, will be greeting us, as well as the Pan African Training Mentorship. This is a college that offers mentorship across Africa, and their representative is here as well. And today we are going to cover obstetric emergencies, because this happens to be one of the major concerns in the maternity sector, or in the maternity department, and in the wards. So welcome, feel free. All of our esteemed colleagues, highly learned, they are here. We have Dr. Amalwa, who is in the house. Dr. Amalwa is a pediatrician who has specialized in pediatrics and child health. So he is one of us. We also have Dr. Meshak, who is here with us, and will be taking us through some of the questions that will be asked and the ones that are commonly asked. We have Dr. Masio Wino as well in the house. This is a chief gynecologist. She has specified in that area. We also have Dr. Miriam in the house. Just allow me appreciate them, because this entire team has made it possible for us to bring this training to you. And I know if you have any question, kindly you can note it down, so that before we finish or at the end of it, you will come and bring your question on board so that we can handle it. And we are here to bring you this training. Remember, I've told you we have representatives from our collaborators, and they are across Africa. Remember, the headquarters of Paramedics Hospitals Africa is in Cape Town, South Africa. So that is where we are based. But we also have representatives in various countries. We are working to capture more countries, but as for now, we have Kenya, we have Tanzania, we have Uganda, we have Malawi, we have Zimbabwe, we have Botswana, we have Ghana, we have Nigeria. Which other country? Those are the major ones, but okay, we also have Rwanda. I'm being reminded we have Rwanda. So feel at home. Any questions, you raise them. So obstetric emergencies. When we talk about obstetric emergencies, what we mean? So the objectives, first of all, by the end of the lesson, you should be able to describe the emergency obstetric conditions, one by definition. Then we shall look at the predisposing factors. We will also be looking at the causes, the pathophysiology, the diagnosis and investigations, and a very important aspect of it, the clinical features. Then the nursing and the medical management of it all, that one should be our concern. Then the complications, and of course management of the complications. So that is what basically you need to know. And now we are going to handle the common ones. So by definition, you should be able to know that obstetrics is basically a branch of medicine and surgery, and it deals with the pregnancy, the labor, and the puparium part of it. So emergency, that one is a sudden crisis that requires an urgent intervention. Okay. So once again, allow me go straight to the emergency obstetric care, because that is what we are going to discuss in details. So this refers to a set of the minimum health, the healthcare elements which should be availed to all women during pregnancy and delivery. So these are the essentials that should be um, availed to all women or to a woman who is in pregnancy and delivery. So remember, it is going to include the saving and emergency measures. These are the cesarean section. We will talk more about the cesarean section. We have the manual removal of the placenta. Those are the common ones because they really pose a threat to our healthcare systems. So we have to know them. Then we have the non-emergency measures, like the use of a pantograph. This one is a tool used to monitor labor. Then the active management of third stage of labor. So this active management of third stage of labor, that one as a clinician, as a midwife, as a nurse assistant, you should be well versed with this, because the active management of third stage of labor is what will help you to remove the placenta, uh, as well as manage the postpartum hemorrhage. So the emergency obstetric care, remember, is a component of a safe motherhood initiative, and the functions as categorized as basic emergency obstetric care, that is the BMOC, then the comprehensive emergency obstetric care. On the basic emergency obs, we are going to deal with the administration of IV antibiotics, magnesium sulfate as well. That is for the case of preeclampsia and eclampsia. We are doing the magnesium sulfate. Then we have the parental oxytocin. Of course, remember that we have the performing of manual removal of the placenta. Okay. Then removal of the retained products. We also have the aspect of the assisted vaginal delivery. That one could be by vacuum extraction and so on and so forth. So performing the newborn resuscitation, that one is an area we need to know. Then the comprehensive emergency ops, we are going to look at the 7 of the above already mentioned, but as well as the 2 that we are adding. And you are saying that we have the performing of a surgery. That one is the CS, the cesarean section, and it includes the provision of the emergency obstetric anesthesia. So we may really require an anesthetist in this case. Then administration of blood transfusion, if at all we have the postpartum hemorrhage. That is the primary postpartum hemorrhage that results in the first 24 hours after delivery. So again, yes, so we are going to look at the examples of these obstetric emergencies. What are we talking about when we say the obstetric emergencies? And these obstetric emergencies, we are going to mention them, but we are going to look at the one that the ones that are really common in our hospital setting. So we have the cord prolapse, that is the cord presentation. Then the antepartum hemorrhage remains to be one of the major OBS emergencies. Then the postpartum hemorrhage, of course, it is the one that leading there. Then you have the ruptured uterus, the amniotic fluid embolism, the acute inversion of the uterus, the fetal compromise, or what we call the fetal distress is a common one. Then we have the maternal distress or the maternal fatigue. Then the vasa previum. We have the preeclampsia and the eclampsia. They are again experienced in our hospitals. Then you have the obstetric shock. Then the shoulder dystocia. So there is a case scenario here. So this case scenario, you can this is a quiz for all of us. You can try and see if you can manage this patient called Lakwani, because she's para 1 plus 3 gravida 5. So that one you go and try, but let us talk something about the cord prolapse. So cord prolapse, what we simply mean, is just a condition whereby you get that the loop of the umbilical cord that um, in this case is going to lie in front of the presenting part, and the membranes that are still intact. So whenever you get the membranes are still intact, and we have this cord, the umbilical cord lying in front of the presenting part, then probably you are dealing with a cord presentation, a cord prolapse. And remember, the pressure on the cord will diminish the O supply. Okay, so that is the oxygen supply. So the cord prolapse, remember, now is used when the umbilical cord lies in front of the presenting part, as we have said, and the membranes in this case are ruptured. Okay, they are ruptured. So let us see some of the causes of the cord prolapse. We are saying that we have multiple pregnancies, especially the twins. So the second twin is the one that normally may present in that manner. Then we have the contracted pelvis. This is a type of pelvis where you get the membranes are ruptured, and before the head is engaged. So contracted pelvis is one of the causes. And then high head, and in this case we are saying that the membranes may rupture spontaneously when the fetal head is still high. Now this will permit the cord to slip downwards. Then that artificial rupture of the membranes, of course the ARM is contraindicated in high head. The low implantation of the placenta, that is the low implantation of the placenta, of course, the marginal insertion of the cord, and abnormally the long cords. We have the prematurity, the preterm. We also have the small for gestation age, babies, because in this case there is more room is in between the small fetal head and the maternal pelvis. Of course, the polyhydramnios, and in polyhydramnios the cord is likely to be swept down in a gush of liquor, okay, when the membrane rupture spontaneously, or as we have said, in the artificial rupture of membranes, the ARM. So the malpresentation and malposition, then the multiparity. So let us go and look at the diagnosis of the cord presentation and the cord prolapse during labor. How do you diagnose them? Okay, so one is the fetal membranes, then the footling breach, and the compound presentation. That one is cord prolapse, and those are the differentials. So the differentials could be the fetal membranes, the footling breach, the compound presentation. And to diagnose during labor, remember, cord presentation or prolapse can be diagnosed on vaginal exam, and this is as follows. On vaginal examination, a soft pulsating mass can be felt. So immediately you feel this mass in front of the presenting part. This is now behind the four waters with the membranes intact. That one, we call it the cord presentation. It's a diagnosis of the cord presentation. Then we have a cord that may be felt in the vagina or seen at the vulva, either pulsating or not pulsating, and the membranes have ruptured. So once the membranes have ruptured, your diagnosis will be cord prolapse. And remember the abnormalities of the fetal heart rate, the fetal bradycardia. Okay, so we look at the management of cord presentation. How are we going to manage if a patient comes with the cord presentation? How are we going to manage it? So one, I've said you are going to assess the cervical dilatation, then you also assess the presenting part, then the status of the cord. That is very important. So whether pulsating or not, you must be able to note that, and as soon as you confirm that the cord presentation on vaginal exam, okay, it's rare, but once you confirm such, then you should remove your fingers, then taking care not to rupture the membranes in case they are still intact. So one thing you are going to do in the management, you are going to reassure the mother and explain to her the situation at hand. That is very important. Then you are going also to ask your assistant, in this case is going to inform the doctor in charge and the theater staff to prepare for an um, emergency CS. Okay, then you are going to provide oxygen if necessary. Then you are going to take the mother to the theater as soon as possible, as the membranes may rupture at any minute. So you need to handle these patients with care. Then the management of cord prolapse. So this cord, we have said that it could be pulsating or not pulsating. Okay, so the management is going to depend on whether it is pulsating or it is not pulsating, and then it's also going to depend on the stage of labor. Is there any cervical dilatation? Then whether she is in first or second stage, that one is really important. Then adequacy of the pelvis, is the pelvic adequate for the management? So if the cord is pulsating, you must act very fast in order to save the baby, because if you do sluggishly, you may lose the baby. And remember, that is not what we are looking for. We are looking to save the lives of the mother and the baby, so you should really act quick. Okay, so that is it. This is just the continuation of the pulsating cord. Then if the cord is not pulsating as well, so the management in details, I've said you are going to perform the VE, then you are going to note if it's pulsating or not, as well as to note the cervical dilatation. And then if cord is outside, then you are going to replace in the vagina to keep warm. That is one. So if the cord is pulsating, this is the summary of it all. So we are saying that in first stage of labor, do not remove the fingers. That one is key. What you do is elevate the presenting part, then you are going to reassure the mother. You are going to position the knee and the chest. Then you are going to tell your assistant to give oxygen. Remember, we are giving oxygen via face mask. Then you are going to inform the doctor as soon as possible. They are going to prepare for a cesarean section. Then you are going to draw blood for cross matching. This is just in case we have a blood transfusion, we need the cross matching as soon as possible. You are going to secure an IV line. You are going to start an IV line. Then you are going to prepare the mother within the 5 minutes or less, and wheel to theater. So this one is as soon as possible. That was if the mother is in first stage. So if the mother is in second stage, this is what you are going to do. First, you are going to explain. Okay, you are going to check whether the cervical os is fully dilated. So check for the cervical os. Then explain to the mother the situation in the way you have done before. Then you're going to tell your assistant to inform the doctor, and you're going to prepare for vaginal delivery. So the differences you need to note is that if is in second stage, you are going to perform vaginal delivery, but if is in first stage, then of course the cord may rupture. So what you are going to do is you are going to prepare for a cesarean section. So if the mass is not pulsating, okay, if the cord is not pulsating, so this is what you are going to do. So it is no longer an obstetric emergency, you need to know that. So you are going to explain the situation to the patient. That is key. Then if the mother is in first stage of labor and the pelvis is adequate, nature is allowed to take its course and deliver a stillbirth. So you're going to have a stillbirth. Okay. Then if the mother is in second stage of labor, you are going to explain the situation to the mother. That is very key. You are going to exclude the cephalopelvic disproportion. Very important. You are going to encourage her to push so that she can deliver. So if the mother is either in first or second stage with a contracted pelvis, you are going to explain the situation first. Then you are going to prepare for extraction of a stillbirth. So in those two cases, we are going to have a stillbirth. Then we are going to now, what are the complications? So asphyxia, the asphyxia of the neonatal, okay, is one of the major complications, as well as the puerperosepsis, the neonatal death or stillbirth due to cord prolapse and the compression. Then the hypofibrinogenemia is a rare one, but is there. Of course, respiratory distress is there. So I don't know if you have any question. Kindly, you can write under the comment section your question so that we come back to it. And were you able to manage the first scenario? Because we have another case, a second scenario that we need to handle. So we go to the antepartum hemorrhage. And in antepartum hemorrhage, by definition, remember, this is now the bleeding from the genital tract in late pregnancy. This is after 24 weeks of gestation and before the onset of labor. Okay, so this one is vaginal bleeding occurring, could be 24 weeks of gestation. Then, as well as we are saying that after 28 weeks of gestation and before delivery. So this one is before delivery of the baby. Okay, before the onset of labor. So what you need to know is the causes. The causes, we have the two main causes, that is the placenta previa and the placenta abruption. So these those are the main causes, but we have others. So apart from placenta previa and placenta abruption, we have the vasa previa. This remains to be, is not a common one, but is another main cause, because we have the fetal vessels that cross the cervix, and these vessels, they are prone to rupture. So the vasa previa is another cause. Then we have local causes as well. Local causes to mean that we have the likes of the cervical polyps, we have infection, we have trauma. So trauma could also cause APH, and we are saying that the two major ones are the placenta previa and the placenta abruption. So if you're talking about placenta previa, you are simply talking about the placenta that is a low-lying placenta. Okay, this low-lying placenta completely covers the cervix, so that one will actually cause the antepartum hemorrhage. And if you are talking about the placenta abruption, what you mean is the premature separation. And this premature separation, it is of a normally implanted placenta. So what you need to know again is the risk factors. So hypertension remains to be one of the major risk factors in APH. And we are also saying that previous placenta previa or previous placenta abruption is a risk factor. Multiple pregnancies, we're talking about the twins, the triplets, so that is it, is risk factor. Talking about smoking of substance, the substance abuse remains to be another risk factor. So if you have a pregnant mother at home, kindly advise them not to take alcohol, not to smoke, because this substance abuse and smoking is really a risk factor. Then we have trauma, we have accidents. Another risk factor that is normally looked down upon is the uterine abnormalities, or the history of a surgery could be one of the risk factors. So another major thing to look at, we are looking at the signs and symptoms of both. Okay, signs and symptoms. So if you see painless bleeding, that one will suggest a placenta previa. Now, painful bleeding is the one that we are saying, with abdominal tenderness is the one that we are saying that is placenta abruption. So Remember, you're going to have decreased fetal movements, then the uterine contractions or the rigidity. Okay, so the fetal parts will be easily palpable. Then the in placenta previa, the fetal heart sounds are usually present. So remember, there is no tenderness in the abdomen. Now you are going to manage. One is bed rest if the mother responds to conservative management. Then you are going to do surfactant tests if the mother has gone into labor, that is 38 weeks of gestation. Then if bleeding starts after 38 weeks of gestation, you are going to examine for a CS. Then if the placenta not felt in the anterior part, you are going to do the ARM, and you are going to start the syntocinon drip to induce labor. So you are going to induce labor in this case. That is if it's 38 weeks gestation. So if bleeding is due to type 2 or 3 and 4 posterior, you are going to do a cesarean section. Then if bleeding is followed by premature labor, you are going to give the 2 doses of dexamethasone. Remember, this one is given just to promote the lung maturity of the newborn. Then you are going to consider the IV fluids, the intravenous fluids. If bleeding is severe, remember you're going to do D5%. This is the dextrose 5%. You're going to alternate with normal saline. Remember, you're alternating, okay? The dextrose 5% with normal saline. Then you're going to give analgesics, of course, to relieve the pain. And the pethidine 100 mg is the choice, the drug of choice, as well as morphine 15 mg. So you're going to transfuse mother once blood is ready. Then, if severe, remember to prepare the woman for emergency cesarean section, and you are going to prepare to receive an asphyxiated baby. So you are going to receive an asphyxiated baby. And so we are going to look at the APH due to the placenta abruption, and we are saying that the causes of the placenta abruption is we have the toxemia, okay, we have the trauma, and the sudden uterine decompression, and the abnormal short umbilical cord due to traction. So due to cord traction, okay. Predisposing factors as well, we have the polyhydramnios. This one is the too much amniotic fluid. You have the external cephalic version, have the multiparity due to the lax uterine muscles, the trauma to the abdomen, then the placental insufficiency in case of anemia. So the patients with anemia and hypertension, they are the ones that are commonly affected. So we look at the signs and symptoms. We said we have the painful pervaginal bleeding, and we have a tender abdomen, we have a constant abdominal pain that does not that is not easily managed with antibiotics. So we have woody, hard, and tense uterus. Then the fetal sounds are absent in severe cases. So the types, we have the reveal type, the concealed type, and the mixed type. So this mixed type is the one that is common because it has features of the revealed and concealed type. So we have the comparison between the placenta previa and placenta abruption is in the notes. You can go through. Then one thing that we need to look at is the management. How are you going to manage this patient? One, you are going to do the ABC. You maintain the airway, the breathing, the circulation, ensure that. Two, you are going to check for vitals and fetal heart monitoring. Three, you are going to do speculum exam. Remember, do not do a digital vaginal exam if the placenta previa is suspected. Take note of that. No digital exam. Don't do digital exam if the placenta previa is the one that we are suspecting. Then another management, you are going to do an ultrasound. This is basically to locate the placenta. You are going to do the blood test, the CBCs. This is the full hemogram or the complete blood count. So we are going to check for the coagulation profile. You are going to check the blood group, and remember you are going to, the blood group is for the cross match. Okay, so you are going to stabilize the mother on IV fluids, oxygen if necessary. Remember you are also going to do blood transfusion if needed, as well as monitoring the fetus. Let me see another thing. The timing and mode of delivery, this will depend on one, the bleeding severity, then the gestation age, and the fetal condition. If bleeding is life-threatening, then you're going to do the emergency CS. You're going to do the emergency cesarean section if there is a life-threatening bleeding or if there is fetal distress. Remember that. And the complications, of course, we have the maternal shock, we have a stillbirth, could be there, and it is common. Preterm delivery is there. Anemia or need for transfusion is another complication. The neonatal death could also come as be an outcome. Maternal death if things worsen, if not managed properly. But the common ones are the pupillocepsis. We also have anemia, I've talked about it. The kidney failure could be there. The PPH due to the hypofibrinogenemia could be there for few living ligatures. So asphyxia of the neonatal, we have talked about that. So there is an assignment here. You can go and try it out and we see. So in conclusion, what are we saying? In conclusion, we are saying that APH is a serious obstetric emergency, and it really needs a prompt evaluation. One is a prompt evaluation. Two, we are saying is going to need monitoring, and three, the management to reduce the maternal and the fetal risk. Then after that, we are going to do the postpartum hemorrhage, one of the commonest obstetric emergency. Okay, so I don't know if anyone has a question or we proceed. So let's dissect postpartum hemorrhage and let's see what we need to know about postpartum hemorrhage. First of all, postpartum hemorrhage is a life-threatening and if not well managed, but the good news is it is preventable and treatable with the prompt recognition and intervention. That is what we need to appreciate. You also appreciate that is the excessive bleeding after childbirth. This one is defined as excessive bleeding of more than 500 milliliters of blood after a normal vaginal delivery. And for the case of a cesarean section, we are saying that it is the blood loss of greater than 1,000 ml. Blood loss of greater than 1,000 ml after cesarean section, or any blood loss that causing signs of hypovolemia. You can say that one is a postpartum hemorrhage. The types you have: primary postpartum hemorrhage, and I told you that this one is within the first 24 hours of delivery. Then the secondary postpartum hemorrhage, this one is now after the 24 hours are up. Okay, so it goes from 24 hours after delivery to about 6 weeks postpartum. Okay, that one is secondary PPH. So the causes, we have the causes. We have the 4 T's. The T-tone, that is the uterus atony. Uterus atony is one of the, in fact, it's the commonest. It is the commonest cause of PPH. The tone, the uterine atony, is the most common. Then 2, we have the tissue, and in this case the retained products of conception. Number 3, you have the trauma. These are now the tears on the vagina, on the cervical, and on the uterus. including uterine rupture. Then we have the thrombin. The thrombin, we are saying it is the coagulation disorders. These are the coagulation disorders the mother could present with. Now, predisposing factors: the presence of fibroids, the maternal anemia, the ketoacidosis, the multiple pregnancies, high parity resulting in uterine scar tissue, then the previous history of PPH or retained placenta. So these are the commonest. So what you need to do as a health practitioner, you need to look out for them. If a mother presents with ketoacidosis, kindly do well to manage that patient with care, because it could easily go into postpartum hemorrhage. Okay, so and remember, the most important thing in management is knowing the cause. So once you know the cause of the bleeding, then you are going to manage the condition as per the cause. What else? The causes of uterine atony are here. The precipitate labor or prolonged labor, mismanagement of labor. This one is one. Could be high dose of analgesics during first stage of labor, or full bladder will interfere with the contraction of the uterus, the rapid expulsion, the retained blood clots, the mishandling of the fundus, pulling of the placenta before separation. So that one could cause uterine atony. And of course, the grand multiparity due to laxity of the uterine muscles. That one is it. So we look at the clinical features: heavy vaginal bleeding. Then this patient, you will agree with me that they will have a low blood pressure, so low BPs, and they have low BPs, they have high heart rate. So the heart rate is high but the BP is low. Then they'll have in physical exam you will see pallor. Then you are going to see dizziness and signs of shock. So they may have shock and signs of shock. So the low BP, the rapid weak pulse, the cold clammy skin, the pallor of the conjunctiva, the palm, altered level of consciousness, these are evidence when the mother becomes restless or drowsy. So those are the signs of shock. So you should manage shock in that case, and you should manage very well. So in management, 1, you are going to call for help. 2, after calling for help, remember the ABC is key. So ABC is resuscitation. Then after that, ensure fluids, ensure oxygen. So ensure you are in a facility that has oxygen. Okay. Then monitor vital signs. So we have the uterine massage, we have the administration of the uterotonics, and oxytocin is the drug of choice. If it is not present, you are going to do misoprostol and augmentin. So you do that. Then in the further management, you may need a manual removal of the placenta. So if it's retained, then remember repair of the trauma, blood transfusion if needed, you are going to do that. Then the surgical interventions. So we have said that the specific management of secondary PPH, then we are saying, 1, you cannot do it alone, so you need a team of healthcare professionals. So you are going to call for help. Then you are going to reassure the patient, reassure the mother, and the significant others. We mean if this woman has the husband who is there, you are going as well to reassure the husband. You are going to reassure them, the mother, and any significant figure that will be present there. You reassure them. Okay, so you are going to massage the uterus if it is still palpable. Then you are going to expel any clots. You are going to encourage the mother to empty the bladder. Remember to give the uterotonics. the augmentin IM or IV. So you're going to give this augmentin either intramuscularly or intravenously. Then you are going to assess all pads, the lining, the soaked with blood, to assess the volume of blood loss. This is important so that we may know if we are going to transfuse another blood. Okay, so we need to know the volume of the blood that has been lost. So if bleeding persists, remember, reassure the mother. Then you're going to discuss the treatment options and you are going to prepare her for theater. So I don't know if there's any question. Okay, there's a question I got about management. So remember, on management, the key goal is prevention. So if you can prevent, and how are you going to prevent? Prevention comes in the third stage of labor. So active management of third stage of labor, that one is very important because it helps you to prevent the postpartum hemorrhage. And in the third stage of labor, we are saying that you are going to administer uterotonics within 1 minute of birth. So immediately 1 minute after birth also you're going to administer uterotonics, and we are saying oxytocin 10 international units you are going to administer intramuscularly or intravenously. So we have said oxytocin is the drug of choice, but remember alternatives, as I've told you. You can do augmentin intravenously or intramuscularly, as well as you can do misoprostol. Then number 2, we are going to do the controlled contraction. Controlled contraction. This is to mean you are gently pulling the umbilical cord while applying a counter pressure. Okay, so you apply a counter pressure on the uterus. This is just to aid the placental delivery. Remember, it's gently, and once you see a gush of fresh blood, then that is it. So another thing in the active management is the uterine massage after the placenta delivery. So you are going to massage the fundus. This is just to encourage the contraction and reduce the bleeding. So that is it about the postpartum hemorrhage. And let me know if you have any questions so that I can respond to them, or our media team, or I don't know if our media team have any questions on their end, because we need to respond to them as well. So thank you so much for attending. May God bless you.